Good morning, everyone. We are going to start our IC on optimizing the complicated and challenging cataract surgeries, the ways and the method. So, we are having the all prestigious speaker with us, those who have lived the way with these kind of challenges, and they will share their experience, their skills, their techniques. So we are fortunate and the opportunity is there. So I'd like to invite first Dr. Arup Chakravarti sir, because he is having a flight immediately after he will move. So over to you, sir. He'll be speaking on the sinking nucleus.
Can I have the slides on the screen? Yeah. So thanks a lot, Nitin, for having me here, and good morning, friends. I'll be showing you two videos where I depict sinking nucleus, different strategy adopted in each case, the eventual outcome, and then what is the best strategy to use when you are confronted with a situation like that. So this was a patient with a moderately hard cataract in 3 to 4 plus nuclear sclerosis. So this is what we routinely do. This patient actually had multi-system illness. He was undergoing renal failure and all sorts of systemic issues, multiple intravitreal injections. So Rexis was adequately sized. Cortical cleaving had a dissection with the Chang cannula. So please don't blink. What you saw just now is a pupillary snap sign. All right, so there is no reason. This patient didn't have a posterior polar element. Patient didn't have any posterior capsular trauma because of injections given earlier. It was done elsewhere, and then there's no history of trauma. Okay, so the eye becomes hard while injecting fluid. So I thought, I didn't think in terms of pupillary snap. I thought maybe the eye has become hard because fluid has accumulated in the bag behind the nucleus, and as a process there is more fluid in the eye, so eye has become harder. So I just let out some aqueous from the edges of the rexis. Eye become little softer, AC become little deeper, and so decompression, that's what, it was not a complete decompression, it was just a partial. So anyway, I went ahead with phacoemulsification. This is a Goider machine, Goider probe. And now here I thought I'd do a stop and chop technique. So I made a deep sculpting, but at this process I realized the nucleus is getting tilted. And so one should actually have a high index of suspicion in these cases, but I had really missed the pupillary snap when I was doing the cortical cleaving hydrodissection. So I thought, let me see what happens. And this patient also was uncooperative. He was developing pulmonary edema because of his renal failure, and he was moving and he was restless. So I didn't want him to be taken up the second time. The nucleus rotation is difficult. So there's a lack of solubility, tilting of the nucleus. We're not able to rotate the nucleus properly. So this is all telltale signs of a posterior capsular rent that has happened. So anyway, I thought, well, now whatever is accessible, I'll remove from the anterior approach, and then the rest of the nucleus sank to the periphery. So if you see here, I have an intact rexis, nucleus has dropped, and I injected OVD so that the PC rent doesn't enlarge, or more vitreous doesn't come out, and stained with triamcinolone acetonide 1:4 dilution, and did a vitrectomy, bilimbal vitrectomy, and using the same cutter to remove the cortex and the vitreous whenever it was prolapsing out. And I decided not to implant a lens. It is always better to keep the patient FAK because patient had to undergo another surgery, and it has to go through the posterior segment, post-Passmann process. So patient was very uncooperative, so I just closed the incision, gave intracameral moxifloxacin, and then the patient went for another round of dialysis. 2-3 days later, patient came back quite high because triamcinolone acetonide. So the posterior segment surgeon went through the Passmann, used a fragmentome, removed the residual nucleus chunk, and then the pupil had become small by that time. So I used 4 ID sucks to give me an idea about where the anterior capsule is, where the rexis margin is. And so the leading haptic goes into the ciliary sulcus, make sure that it doesn't go through the PC rent, so you need to have proper awareness and wrist control. Leading haptic goes into the ciliary sulcus, the trailing haptic also will be compressed into the ciliary sulcus, and the optic will be captured buttonhole through the rexis margin. So before closing such cases, it's always important that you stay in the anterior chamber with triamcinolone acetonide dye. There's no vitreous. This patient survived for a couple of months more, and he was quite happy with his vision. This was another case, a posterior polar cataract. Fellow I had done earlier, patient had done well. So this is a wall-like opacity, and this is the spindle-shaped defect of the posterior capsule. So here, right from the word go, things were not happening well. So I do not use any hydro steps for post-polar cataract. I use a cyclodialysis spatula, hydro-free dissection all around the anterior capsule. So that was under the anterior capsule. So that was done. I'm using phaco now. I realized that my phaco power is not adequate because there was a translation movement of the nucleus. My vacuum was not adequate because the chopping did not go well here. As you see here, I should have stepped up the phaco power and I should have increased the vacuum. And then too much of lateral separation is happening where there is a posterior capsule is questionable, the integrity, and it was cut open. So here, I tried to remove as much of the cortex and lens matter as possible. And then there was last chunk actually went into the posterior segment. So now this patient was planning to go to Gulf. So I didn't want him to come for a second surgery, and I thought, I'll go for, posterior assisted levitation. So I made a sclerotomy with MVR blade using a Sinskey hook and adequate OVD injection behind the nucleus chunk and in front of the nucleus chunk. Try to levitate the nucleus. It was quite difficult because nucleus already is in the posterior plane. And from this anterior approach, past line approach, it is very difficult to go behind the nucleus and push it up because the angle of attack was just not optimal here. But anyway, I managed, after a lot of manipulations, I managed to take out the lens matter from the anterior approach. The small chunk of lens matter you still see here. So I did vitrectomy. The last chunk was again removed using the posterior assisted levitation, and I kept a single piece, 3-piece lens in the bag. And finally, so at the end of the day, so patient had done extremely well, so looks very nice. I presented this case as something, which to promote posterior assisted levitation, such a useful technique. 1 year later, the patient went to Gulf. He came back with hand movement vision, with several months duration. So patient by that time had developed a total RD with PVA D2 and was advised surgical correction, and patient was not willing to undergo any surgery. So my take-home message for you will be: if you have a sinking nucleus, just leave it alone. Don't do a pass planner process assisted levitation. If you want to do a proper vitrectomy, use a fragmentum, remove the fragment if you have the expertise yourself, or if you have a retina surgeon in the operation theater. Otherwise, that was I did for the first case was forget the nucleus. Let the nucleus settle in peace in the posterior segment. Do the anti-segment toilet. If possible, keep a lens. If not possible, just close up, keep the patient effective. And as a second stage, with the fragmentum, the nucleus chunk can be removed and an appropriate lens can be used. Thank you very much for your kind attention.
Thank you very much, sir.
And this is the second part of the take-home message. I'll be expecting you to, requesting you to help me out when I contest for the post of Vice President next year. Thank you very much.
All the best, sir. All the best, sir.
So Dr.
Thank you.
You recommend that there should not be elevation, should not be tried.
Yeah.
It should not be tried.
It looks very, what should I say, sexy. Yes. It looks very, seductive, I would say. It looks so nice. But then in the long run, say there are people. David Chang has written an article. Richard Packard has written an article. I also put it up as a case report before the retinal detachment happened after 1 year. So we are managing the patient over a period of time, not just what I have done on the table.
So I think the message is very clear. One should not do the heroic. One should not try heroic things. Yeah?
And after how much time do you do the operation after the dialysis? You said the first patient was on the dialysis.
No, as soon as the patient was fit, he undergot, maybe the next day patient came. Yeah, we don't want to wait because he is surviving on his peritoneal dialysis. So as soon as he was fit, he was able to lie down. They did a pulmonary edema again, they become restless. So maybe in the morning dialysis was done and afternoon I did the surgery.
This particular patient was so much complication, but I believe the general patient, those who are on dialysis, the next day of the dialysis we are doing most of the surgeries. Yeah. It's very common, yeah.
Same we try. Once the dialysis is over, we do it.
We do it the next day. Thank you, sir. Thank you very much. So, is there any comment or queries regarding this? The next speaker is Dr. V.P. Kashyap, sir. He'll be talking on rescue for VR surgeon in combined cases.
Hello, sir.
Normally the VR surgeons, they rescue the anterior surgeons.
Okay, sir. Thank you
Good
very
morning,
much.
everybody. So my talk is on helping the retinal surgeons because, they inject the oil, remove the oil. buckle, they do the buckle, and if something wrong goes with the buckle, they have to remove the buckle, the extrusion of the buckle, removal of the buckles. So that makes the cataract tough to handle. So in a combined surgery, the posterior segment surgeon is there and there are other OT and you are doing in the anterior chamber OT. So if the two surgeries are combined, you should have two surgeons because normally all the cataract surgeries in these cases are complicated. So it takes a lot of time, and when this retinal surgeon has to do is the retinal surgery, it's better to have two surgeons. And these, as I told you, they are relatively complicated. You have to put the pre-placed irrigating cannula. They don't want any chemosis. The cornea has to remain transparent. There should not be any unstable IOL, otherwise they will face problem. The cataract surgery should be done without any injury to the pupillary margin because the pupil will get constricted and then they'll have problem. And if you are going to put any stitches in the cornea after the trauma, they don't want any striations in the cornea because the image of the retina will get hampered. And all the cataract wound has to be watertight and main incision and side port, and they do not want any soft eyeball. Problems, they can be big bubbles of the silicone oil. They can be, regularly collapsing the anterior chamber after with the posterior capsular bulge. Difficult capsular access and cortical matter peeling and aspiration. There is a bad funnel glow if there is a vitreous hemorrhage. If untied buckle done before we start the cataract surgery, recurrence of iris prolapse is there because sometimes they do the buckle and they say halfway, they don't tie it and they say, please do the surgery for the cataract. And if there is saponified silicone oil in the anterior chamber, they hide the cataract. You may find a rock hard cataract behind it. And traumatic subluxated cataract can be a real challenge and may have to leave the patient aphakic. So let's see some videos. You see, in this case, the bubbles are coming, so I'm very, very cautious that there might be some PCR. And look at this, the AC keep on collapsing, and then for God bid, there might be some, the PCR. We have to be very, very careful. The silicone oil bubbles keep on getting so you have to know your limitations. You also be concerned that there might be some sometimes when they inject the silicone oil, it puts subculture. You have to remove for that. And not all can be removed, but then whatever you can, you should do it. And then while cataract surgery, there are some specifications that can be not over the before tying the belt buckle, they said, please do this surgery. In such cases, the iris is and no matter what, again, at traumatic cases, but then I have to leave the patient you make them feel comfortable that it is all done. And my teaching to my fellows are, do not touch the cataract of a retinal surgeon unless and until you are very, very comfortable. Thank you very much.
Thank you very much, sir. So is there any query or input from the other, any query or question or comment?
The message is very, very clear.
Yeah.
Very, very clear. Don't try to be heroic. Again, what I said in the first talk, let it to be your surgeon do the best job. Leave it there, clean the anterior chamber, and let, if required, do suture immediately and send it to VR surgeon.
Thank you.
Okay, sir. Is there any special, anticipating the challenges? Do you do anything extra other than in your preparation thing, like post VR surgery, if the patient comes for a very hard grade cataract, wherein the chances of PCR is also higher? So, apart from maneuvering any, OVD's preparation or anything, any maneuver that you specifically plan for such cases?
First of all is history. Like when there is a nucleus drop or segment drop in the posterior segment, the anterior segment tells the posterior segment surgeon, एक छोटा सा टुकड़ा नीचे चला गया है. And when the retinal surgeon operates, he finds a big chunk. Same way, the posterior segment surgeon has to tell us whether they touched the posterior capsule or not. Even while giving the injections, whether they touched the posterior capsule or not. What are the chances of the capsular dehiscence? We have to take the proper history and talk to the surgeon. That is what helps you, because in many cases, if the pupil does not dilate, you do not know anything. It is you take it as it comes. Okay, and by the end of this conference, I think everybody has become the expert of aqueous fixation surgery.
No, in post we are silicone oil surgery when you're planning a cataract with SOR. So when you're doing the cataract, would you put the trocar first to reduce the pressure, or you will finish the cataract and then shift to the VR person for him to do the place the trocar and do the SOR?
Sir, you must have seen that
one video I saw.
In each and every case I put a irrigation cannula. Plus, if I anticipate any PCR or if I anticipate any complications, I keep the irrigating cannula behind.
So this is very important actually, because when you have a silicone oil, because the silicone oil floats anteriorly, your AC becomes shallow and the PC is always convex, and it becomes like you're operating in a hard eye. So if you place a trocar before, even if it is a wall 25 gauge trocar, the moment you pierce, the IOP comes down a bit and your AC becomes deep and the cataract becomes very easy. So always when you're doing this patients with combined surgery, I would advocate that first place the trocar.
And like Professor Arup Chakravarti's first case, when there was a pupillary snip sign, I would have put the Aioc cannula. So that has reduced it, and put the irrigation cannula. And the moment you open the nucleus, the remnant nucleus is there to embrace you. Take it out.
Okay, sir.
Thank you.
Okay, thank you very much. The next speaker is Dr. Vinod Kumar Arora. He will be speaking on small pupil, big problem.
Sir, हम जा रहे हैं तो फोटो नहीं हो क्या?
आप जा क्यों रहे हैं सर? 2 मिनट रुक जाइए, फिनिश होने दीजिए. Your input will be required in all the talk. Don't think that you are just speaking on your presentation.
Sir, bear us. Dr. Kashyap, bear us for some time. So, good morning. I'm going to talk a problem which is called the small pupil, but it can cause big problem to many surgeons. So the question comes, what is a small pupil? It's a 2 millimeter is small, 3 millimeter is small, or 4 millimeter is small. So it depends whether on the surgeon's skill and technique, intraoperative situations, and properties of the iris tissue and the pupil. So first we try to do with the pharmacological stents like tropicamide, cyclopentylate, and NSAIDs. These should be used regularly. Then comes the viscomydriasis, Helon, soft shell technique, disco. I'll just cover these things. They dilate the pupil and you can continue the surgery. Pupil stretching is done to know whether the pupil is elastic or it's a rigid pupil. Then if required, sphincterectomy can be done for rigid non-dilating pupil. We have to keep the fluidics low in these cases, and chopping technique is preferred in these cases because that causes less energy and less trauma to pupil. Restrict manipulation to the pupillary center, and preferably use a bimanual IA that makes the thing much easier. The question comes, what are the problems if we got a poor dilating pupil? It reduces surgical space and we have to make a small rhexis. That causes less visibility of the peripheral lens. There is a chances of iris prolapse increased. There is a retained cortical matter in the peripheral capsular bag which we can't see directly. Sometimes one haptic of the IOL may be in the capsular bag, other may be in the sulcus. Then increase post-operative inflammation, corneal edema and CME are common in these cases. The question comes, what to do? I think IFS will be covered in the next talk, but any eye can have IFS. So reduce your threshold for using pupil expansion devices. If there are synechia, release them. Peripheral membrane is there, you have to cut them. And try to use intracameral injection of the combination of mediasis and local anesthetic. Most of these don't work, but if you get some synechia and other things, these things will work. Then test and distinguish the elastics from the non-elastic rigid pupil. So we have got two type of pupil. You have to see very clearly why there is a meiosis is there. Unlike the non-elastic myotic pupil, the IFS pupil immediately snaps back, right? And its original size come to original following the attempts to stretching it. So you have to remember the small pupil and IFS has different mechanism of their pathophysiology. So managing a small pupil, first we try with the mediatics and viscodilation. If it dilates well, then we can proceed with surgery. And if it doesn't dilate, then we have to analyze the pupil of adhesions. If there are adhesions, we have to break adhesion and do stretching. If required, we do the expansion devices and proceed with surgery. Or if we break the adhesion, we can use mediasis and viscodilation after breaking the adhesions and proceed with surgery. If it's not dilating, then we have to use again expansion devices and proceed for surgery. So we have to manage depending on the stage of our pupillary, how the condition is there. So coming to the iris hooks, this is very easy to use. I could recommend for the beginners to start with iris hooks, then switch over to expansion device, so they can have a feel of these things. Then it's much easier to switch over to expansion devices. It's a very you can mark incision initially, because sometimes the cornea, if you make multiple incisions, you can't see where it's gone. You can put a trapin blue or any marker there, or even you can dip your side port knife or the MV are using, dip in the trapin blue. You have a lot of inks where you're using toric lenses. Those pen can be used. You can stain them and just put inside. So you'll get a clear view where your incisions are made. A hook should be planned well in advance, as it is to be placed in the fecund incisions. Limbal incisions are preferred in these cases. Don't go directly corneal. You have the stopper retracted, hold the stopper, utilize the tented portion. Once you put a hook, then slightly stretch it, you get a tented position. Then you could put another hook and slightly move it down. That will be much easier to put it. And avoid over retraction and asymmetric retraction of the hook to be avoided. When used with capsular rhexis, use second instrument. Suppose rhexis is there and you want to put it, then you have to use second instrument to lift the iris and then put it there. Otherwise, you may catch the rhexis also. And be careful in deep set eyes while removing especially. Now we come to the expansion devices. I think volume is not here.
Side-port stab incisions are made parallel to the iris plane, opposite to each other.
So this is being soon going to be marketed in India. A very good device.
The anterior chamber and raise the pupil. The APX device is inserted through the stab incision.
Audio
So-
thoda sa.
All right, so I'll just cover. So there is no intraocular manipulation. It's a fast and easy and safe positioning and removal, efficient iris expansion. Minimum incision size is 1.1, so you can go from the side port, and it's made from nylon, This is a iron pupil expander. This is a little bulky but very, very good. The advantage of this is it provides a 360-degree exposure. I mean, it is stretching the pupil 360-degree. So there is not a pinpoint or any points which is stretching too much. And you can easily do any manipulation without touching the pupillary margin. Everything is free and it's easy to use and easy to take it out also. So disengage and take it out. It's made of polyurethane. It's a very soft and resilient material that is gentle on intraocular use. It's a fixed channels. Height does not compress and pinches in the iris during insertion or removal, and completely 360 engagement of the iris and eliminates distinct stress points. You get a 6.3 mm of circular pupil. That's good for doing any surgery. Manual link, I'll just take 1 minute more. It's a 2.2 millimeter incision. There is a gentle expansion. It has got 8 points of touch. You had to use high viscosity, of course, with all these. And manipulating is classic. Just a small video for the beginners. Better to use with the injector. And normally it engages the pupillary margin. If not, you can do it from the side port. And taking it out also so very easy. Now we have got our own Indian like BX pupillar expander, which is a very, very popular and very good device, and it's very cost effective also too. So we have got the third generation Bhattacharjee ring, a flexible jointless hexagonal polyimide ring. Now we have got 5.5 millimeter pupil expander. Now we got the newer version also, which provide us a bigger pupillary margin and especially good for rigid pupil. It's a bit thicker but quite good. Besides this, we have other rings like Gupta ring, which is a quite good and cheap, but it's little bulky. So initially you may find it difficult to use. So easy to insert. You can use any any forceps. You have to insert it from the main incision. And got a good hexagonal pupil. Removal is again very easy, just single tap, you can easily remove it. Thank you very much.
Thank you very much, sir.
A word of caution. Dr. Vinod Arora is one of the expert surgeon of India. He can do anything. Don't think that these devices to put it in and take it out is all that easy. It's not, sir. The iris hook is good. So, sir, I have certain things. The pupil is expanded, fully dilated. The moment we start the surgery, make a first chop or second chop, the pupil constricts. So you put the visco, it doesn't dilate again. So should you be using again this phenocane eye drop? Will it dilate?
We should try it, give it trial. Most of the time it doesn't dilate, but you have to give a trial of it.
I don't think it dilates. What do you
Yeah.
It won't dilate. It won't dilate. Only
Yeah,
fatigue-
most of the time it doesn't
fatigue
dilate. That's something.
Yeah. So I go up to 4 millimeter of pupil is there. I don't mind because take my words. If you give a more corneal incision, you'll be able to do a cataract surgery without the recurrent iris prolapse. Even I go up to 1 millimeter from the limbus, make the corneal incision. I generally do up to 4 millimeter of pupillary size cataract surgery. So take care. Number 3, the most commonly used dilator is iris hook. So if the iris hook is near the of the nasal side, this nose, naak देखने में तो लंबा अच्छा लगता, but they're in trouble when you're doing cataract surgery. So those nasal iris hook should be cut. So it is not, it doesn't bounce back and then there is a disturbance to the iris hook. So I had to make these 3 points very
That's I
clear.
told you, the deep-seated eyes, you have to cut it and then place it. Yeah.
Thank you.
Thank you, thank you.
Fantastic, sir.
So our next speaker is now the chief instructor of this course, Dr. Nitin Dira. He is one of a prolific cataract surgeon, has contributed enough for preventing blindness in the Aioc region. So over to you, Nitin.
Fantastic, sir.
Thank you, sir. So I'll be speaking on floppy iris. We all know that floppy iris is one of the very challenging when it's in full color, when it's in true color. It's become challenging to even the experienced one. So we all know the triad. It was first described by Chang and Campbell way back in 2005. And the common culprit for this particular entity is the drug which is very commonly used in elderly, that is a drug for BPH, alpha A1 antagonist. And this is characterized by the entity with the triad of iris bellowing, prolapse, and progressive meiosis. So the risk factor is very important when you are anticipating that this is going to be a difficult one iris prolapse and difficult one IFIS rather than the milder is the pupillary dilatation one, and the patient is on which medication, because there are newer drugs for BPH which are known to have much lesser risk for IFIS compared to the traditional one, that is tamsulosin. Apart from this, we need to know that even without any drug in the history, this entity can have on table and make the surgery challenging. Apart from these drugs, hypertension is also an independent risk factor for the severity of this condition. So once you see the management, the first line of the management should be anticipation of the severity, looking at entire cataract surgery. I mean the grade of cataract, the other things which is there in the eye, apart from the poor pupillary dilatation and the history of tamsulosin or like drugs. These all things you need to make in consideration, and you need to prepare the entire OT and your mindset for this particular complication. So in intraoperative management, as rightly discussed, alpha adrenergic agonist should be done, should be there. The phenocane should be there, different kind of OVDs for the dilatation and making the iris little more disciplined should be there. So in any challenge, collateral damage what we are producing. In any case, what we should try to do as much as smooth and normal, we should try to take the way out. So this is the case where we are seeing that dilatation is good, but in the beginning the iris is starting prolapsing, and this kind of prolapse where the iris seems to be very fragile, we should identify it as this going to be an IFIS. And what I usually do, what I'm advocating in, I usually used to put viscoat on the margin and the iris, and because of this cohesiveness and stickiness of this particular OVD, this works in most of the cases, at least in my hand I am experiencing. Whenever pupil is in slightly moderate dilatation also, I am able to manage such cases without much of the difficulties. As I said, because this OVD, particular OVD, it goes and sticks on the surface of the pupil margin and on the iris, so it doesn't allow the iris to be that much indisciplined of the behavior of the iris. So if you can easily manage the nuclear management and you are getting the giving the less chance of pupil margin to come on the phaco tip, then probably the iris stays away from and you manage the case. The next case you are saying that this is even the pupillary dilatation is poor, but I will follow the same. The patient is on atropine pre-op 1 week. that I usually follow whenever I know that the discussing the patient. And then on the margin, I'm applying viscot, and on the pupil also, the remaining part, not in the center. So then, putting the center free of this particular OVD, I try to manage keeping the iris tip in the center. And whenever I feel that the pupil margin is trying and coming again, and the effect of that OVD is waning, I reapply it, especially on the surface of the pupil, pupillary margin, and remaining iris also. And most of the cases I keep the fluidics on the lower settings. So this is how I usually used to manage these cases. And in IA you can lift with the irrigation, and you can see wherever the things are. You can easily pull the remaining cortex and put the lens in place. This all causes minimal trauma too, and the disfiguration which is possible with the iris hook and even the expander rings. So this is the last case I want to show. This is the patient is having history of tamsulosin also, and the inferior margin. This is the maximum dilatation possible with the fibrotic band. And this was the weird, the axial length was 28, the L power was 8. So I just cut the band first. And since the another challenge here was the high myopia along with the softer cataract, and this patient had the other eye, the biometry was 21-22. So I was a little afraid how the intraoperative behavior will be. One important thing in any challenging cataract surgery is you need to keep your head little cooler, and if the challenges comes, you need to slightly reduce your speed and think in between that what are the ways with which you can manage the complication, rather than sticking to one complication and then doing the other. So slightly slower surgery would be better in any complicated case, especially in initial learning in general. So and then once you have managed the nucleus, then the things becomes always easy. So this was the POD1. This was the pre-op and the post-op. So to conclude, I said that an appropriate preparation, the mindset along with the backhand, is very much essential for any complicated case. A thorough understanding of the risk factor apart from and the cataract, along with the grade of cataract and everything you need to keep in mind in your consideration. Communication with the colleagues of the other specialty like urologists, especially if they have not started and the cataract age is there, then they can be communicated. They can ask us simple history. If the planning is there, go for the surgery first, and then we will start BPH medication. So this can also be good. Follow the science and learn from the experience. Thank you very much. Any
Nitin,
comment on?
I wanted to ask you, you know the patient is on tamsulosin preoperatively. So what steps do you take to prevent if IFIS intraoperatively when you have a patient who is on this molecule?
I usually pre-operatively, I usually 1 week at least prior to I prescribe them to go on atropine 1% TDS for at least 1 week.
So the studies have said that atropine 3 times a day, 2 days before the surgery, and your floppiness decreases.
Yeah,
So starting atropine is very important pre-operative.
very, very
This
important.
is very important.
And phenocan along with atropine, it works good, sir.
Yeah.
If you will just give phenocan, in such cases, there may be poorer dilatation, but if primed with atropine it is there, then it gives slightly better dilatation.
And of course, intraoperatively you demonstrated everything very nicely. What I would recommend is a soft shell technique because of the IFS shallow IC, coating of dispersive something like viscoat on the endothelium and a spacer like a cohesive viscoelastic to maintain the AC deep and the iris pushed down. This is very important.
Rather than endothelium, in this particular entity, I advise to put viscoat on the iris surface, because this is very much sticky. So once it sticks on iris surface, it never leaves. So that way the iris becomes much disciplined. Thank you very much.
My one point and message is, if there are such cases, you must write down in a OT note that it was a non-dilating people, because finding a small piece of nucleus it will not be a surprise. You can get it. So if you write a non-dilating people, at least you save yourself. If it goes to your colleague, he knows it, and if it goes to the court, they know it. So that is very important.
Not only in the OT notes, I would recommend preoperatively when you see the patient's
Yes.
dilatation, it should be a habit. 6 millimeter dilated pupil, 7 millimeter dilatation. So a lot of times the sisters who are there dilating the patients, they empty the whole bottle. Sir, pupil dilate नहीं हो रहा, नहीं होगा. Two drops, one drop to 15 minutes apart 2 times is just sufficient. So if you document it during the OPD hours only, what is the maximum dilatation achieved, that also is a good SOP actually.
And again, it's very important to, during the examination, dilate the pupil and see how much dilatation he gets getting. So that's again, you are already prepared if the patient is dilating or not properly. So it's a part of routine examination. You check it by dilating yours, dilated fundus examination. Secondly, always make sure the patient tells about the medicine he's using. Sometimes they think it's not important to tell eye surgeon, I'm using this one, I'm using hypertensive. Normally was asked for hypertension, BP, but whether he's taking for anything for prostate or something, that's again very important.
Yes, sir. Yeah. The next speaker is Dr. Amit Podwal, and he will be talking on intumescent soft cataract, the tips and the tricks.
Thank you, Nitin, for inviting me as a co-instructor for this course. So it got no financial disclosure. We all know that macular intumescent cataracts are swollen, congested, and this hydration of the lens matter with increased intralenticular pressure. So what problems we face while doing the cataract surgery is difficulty in visualizing the anterior capsule. The capsule is stretched and more convex. The peripheral split on the anterior capsule at the first puncture is always seen, and that leads to a sign called Argentinian flag sign. And sometimes this liberated liquefied cortex obscure our view. And there can be a peripheral extension of the capsular rexis midway also. And we all know that CCC is an essential step for a successful phaco surgery, and performing this CCC in a white intumescent cataract is a great challenge to even experienced phaco surgeon. So what is described in the literature to prevent this is a mini rexis, wherein we do a small rexis, finish off the cataract and then enlarge the rexis, or you have the snail pattern or the onion pattern ring rexis, where you start the rexis initially small and then wheel it off like a snail pattern or onion ring. Then you can do a heart shape rexis described by Mohan Rajan, the Pancho rexis, which is done with the pre-chopped settings of the phaco settings with the phaco probe. But what I recommend is this. I'm just going to show a small video of how to manage this. So as I told you, always stain the anterior capsule with trypan blue. Uniform staining is very important. Then as cohesive viscoelastic is injected. A 24 gauge needle mounted on a 2 syringe is placed in the center, and so the moment I aspirate, the whole convex anterior capsule has been concave in the center. Mid periphery bulge is there. You are very steady in this so that there is no extension to Argentinian flag sign. Now you are decompressed in the center, and with the help of a capsulotomy needle or a forceps, whatever you are comfortable with, begin with the small rexis. You saw I am in the mid periphery only. The mid periphery bulge is there. I am within that. Now I am doing a snail pattern or an onion ring pattern. So there is a very control. When you are doing this, always make sure that the VC is well formed, no shallow or the VC. The flap should spread nicely. You should make small tears and not large tears. So this way you get more control. This is snail pattern rexis, and I am within the bump of the mid periphery which is there. Once you have done the phaco, you are injected the IOL, you see that the rexis is decentered. You can refashion. You can just refashion the rexis by using the micro wires and the macro rexis. And whatever coverage of the optic you want, you can just go ahead. You can see very nicely the whole rexis is being refashioned. So nothing to worry if your rexis is just decentered. You always have a good control with the use of this 25 manual macro wire. One more please. See, I am entering into the center, staying there steadily. You can saw the decompression. I have tried this with the 5 mm series, 1 mm series, 24 gauge works best. Again, you have to learn to do the rexis with both hands. A good phaco surgeon is one who can operate with both his hands. So your left hand also should come into dominance. You can see I felt that if I go to the main mode, I will have an extension. So I went to the left side mode with the left hand, started the rexis. And you can see in this also that there is a very good can't go outside. Another technique is give one shot of single shot of yak laser, one shot give in the center of the entry capsule in the yak loop. So the moment I give the shot, there's a gush of blood falling down. Just give one shot, then shift the patient to the OT. By the time the patient sits on a table, the whole integrity of the machine is less convex and your life becomes more easy. You can see the lateral view of the same procedure which I'm doing. One shot and there's a thick gush of fluid coming out. And there's nothing to worry. We have already done the study and I've published it also. So this is how the opening of the laser shot looks. It's a stellate pattern shot, so there is no peripheral extension. The pre-YAG OCT and the post-YAG AS OCT, you can see there's a definite increase in the anterior chamber depth. And we had done this study in which 52 eyes of the 52 patients were enrolled. It was a prospective study. And what was the conclusion? That ND-YAG laser capsulotomy is a safe and effective technique in reducing intraarticular pressure and avoiding intraoperative complications in mature intermittent cataract. This was published also in APJO and it was also showcased in the feature in AO Academic Asia Pacific region. We did one more study taking 100 eyes of 100 patients in which we compared two decompression techniques. One is the YAG capsulotomy and one is a needle decompression with 24 gauge needle. And the conclusion was lens decompression technique reduces the need for repeated entry of instruments into the anterior chamber. A perfect central opening is achieved in a single attempt. Not only the complication is less, but there is a significant increase in the anterior chamber depth, and which in turn increases the ease and comfort of the surgery and reduces the surgical time. And this won the best physical poster in Mumbai AIOC. So this you can see this was a case of mature intumescent cataract. Let's look at 1 minute, right? Yeah. So this was a case. Sometimes not only what phaco settings you can do. You can do a slow motion phaco when you are dealing with intumescent cataracts because most of the time they are soft. But sometimes it can be hard also. So this pre-chop technique works best. What does the pre-chop does? Basically by doing the pre-chop, you are dismantling the whole nuclear fibers. So if it is a soft cataract, it will just come in the epinucleus mode also. You don't have to give any energy. But if it is a hard cataract, because you have decompressed, you can clearly reduce the CD at the phaco time by doing this pre-chop technique. There are a lot of pre-choppers available now. I am fond of Mohanda's pre-chopper, Pradeep Mohanta, our own surgeon from Northeast, and we have a Marsanda pre-chopper also from Bangalore. Dr. Marsanda has invented this. So you saw in this case also the rhexis was very small. So I've given a small tangential nick with the help of a microrhexis forceps, micro 1R scissor. I gave a small tangential cut, and then with the help of a microrhexis forceps, I was refashioning the rhexis. So in your cataract set, you should always make sure you have a microrhexis and the micro 1Rs. A 25 gauge does wonder. It's such a fine instrument, and it saves your life properly when you are dealing with this type of complicated cases. So you can see a good coverage of the anterior capsule over the optic is seen. It's a short of time. This is another case wherein I've used a pre-chopper. See, the rhexis is done. I'm doing the pre-chopper. You get a very nice cracks. These are soft cataracts, but with this pre-chopper technique, your CD really decreases. We've done a study also in this. We compared with the pre-chopper technique and the stop and chop technique, how much is the CD, and the CD is really low when you do a pre-chop technique. So the tip to manage and prevent Argentinian flag sign in mature intumescent cataract, basically I would say is intralenticular decompression. And how that can be done? It can be done with one of the two techniques which I have already described, that is ND-YAG laser anterior capsulotomy or a slow and cardiac decompression with a 24 gauge needle over a 2 cc syringe. Thank you.
It was a really good presentation. Any queries or comment anyone like to?
So I think very well shown. Yeah, there are a lot of ways to do it, and you try most of them things and see what is good in your eyes. You can use pre-chopper. Only thing you have to be well trained for that thing. It's very good, but a little risky for the beginners.
Sir, anytime have you ever tried the ironing of the anterior capsule?
Yeah, so
That
there are
was very
there are
good.
different terminologies we call the lenticular massage. What
Lenticular
Dr.
massage,
Dr.
yeah.
Harvansh Lal says that before you do the rhexis, just take a spatula and massage it, so that basically you are converting the anterior chamber and the posterior chamber in the interlenticular compartment into one. But somehow in this cataract, the zonules are a bit loose and weak. So I tried doing this, but I was not really comfortable. I felt this is a better thing, that the needle aspiration works really nice. And if you have, if you don't have time, you can always tell one of your consultant that give a shot and send the patient. By the time the patient comes, we know that it will be a central opening. There is no skill involved. Just one shot of YAG and send the patient, and you will be able to do the whole case comfortably.
I do massaging most of the cases of such cases. It works too good.
No, staining will never enter. See, once you stain the entire capsule with trypan blue, you wash the dye and then you put the visco, so the entire capsule is stained. Now, when you punctured it, only that cut end is visible. So anyway, when you are going to do the rexis, the cut end is going to be visible. The stained entire capsule will be visible. You saw all the cases, the capsule was very well demarcated with the stain. So
You can
stain.
do hydro in the beginning slightly.
Yeah, yeah.
Staining you can do any stage.
Even
got
there are
beyond the
studies
rexis,
to
yeah.
prevent
Before was
PCO.
Yeah,
Ideally before visco.
yeah.
No, even there are
if,
studies
if you
to.
made a rexis and you finding it difficult to complete, you can do stain it
Yeah,
at
yeah.
that time also.
So that's what I'm saying. That trypan blue is used to prevent PCO also. So once you have done the cataract, you can also wash the capsular bag with trypan blue. It is already published, but because the data is less, people are not following it. So there's no harm if if you restain any time in the surgery. What is?
What Dr. Amit is saying, and you are asking, it is the affinity of the dye to the capsule. So at any stage you apply the dye, if it comes in contact with the capsule, it will stain it. And what he has done, the same study published from the Jaipur, that if you do a hydro by the trypan blue dye and leave it for some seconds or 1 minute, then it prevents the PCO also.
So the
that is
next
special
speaker
study
is
done.
Dr. Virendra Agrawal, and he'll be speaking on pearls for the Yamane technique. Over
Thank
to
you,
sir.
Nitin, for giving this opportunity. So, Yamane technique, you all know that is basically a technique of scleral fixation of the IOL, and in this particular thing is used that the haptic is fixed out of the sclera, not within the sclera itself, and because of this it is having a longer stability. As till now what we have done for almost 6-7 years, the results are very good, and the patients are having a centration also which is very well centered, much more often centered, and is having a stability like this. The patients who have undergone VIA surgery after this, we are also able to maintain the anterior posterior segmentation and the silicone oil stays there. There are few things which are very important. Is basically that it should be marked centrally. It should be a 180-degree placement of the two haptics at the inside the sclera itself. So there is a special technique by which you do mark, as we can use the marker for the toric IOLs. And after making it, the marking, it is very important to use the preferred IOL. We are having a maximum experience with the Johnson sensor type of IOL, and there are few published studies which say that the CT Lucia is slightly better, but we don't have that IOL availability in our OT itself. In case of plant surgery, it is different, but when it happens intraoperatively, some complications happens for which you require a Yamane to be done, then we use sensor. So the important things, you just require needle, the microscope forceps, the trocar. We prefer to use this trocar into all the patients to do a complete vitrectomy or the required vitrectomy at least, and the low temperature cautery. And the important thing is that you should be very cool, calm patient while doing this surgery. Routinely we do phaco. Here phaco is not required, so you have to think and plan. And things are simple, like the 1 port or 2 port for the posterior chamber fluidics is important choice, and you can choose accordingly. I will be showing the two cases almost simultaneously with the pupil which is having good dilation like this, and sometimes the pupil dilation is not very good because of the some complication happened in the prior surgery or some other reason that the complications may be because of the poor pupillary dilation. So I will be running the two surgeries together almost for the same steps, in which one we are having the iris hooks to keep the pupil dilation and making it easier. And the discussion was going in the previous talks that you cut the nasal haptics and other haptics. You need to have a comfort to yourself and to the patient both. And important thing that eye should be centered during the surgery. Otherwise, because of the iris hook, if it is getting tilt, the things will happen not the way you want. So there is a different choice of placing this 1.5 to 2.5 depending on the diameter also, and depending on your choice that what size of IOL you prefer. If you go nearer to the limbus, there are chances that you may pass through the ciliary body or the iris, and the bleed may happen intraoperatively. You can go directly 3 millimeter incision, or you can have different things. Slight flanging like this of the internal rib helps you during manipulation, particularly when you are doing with the trailing haptic. And the eye should be firm before you enter the needle. That is very important. So fluidics here plays a role when you are having a 1 port for the fluid to keep the eye really tense. If it is not tense, then applying this needle may not be happening the way you want, because you need to have a scleral tunnel inside and then it should enter into the thing. So you have seen that I am entering this going plane and then enter into the vitreous. The similar kind of cases where the iris hook is used, and when you are inserting the IOL, it is very very important. You may have some modification according to your comfort, but what I do is that I just put it up to here myself, and I will go inside and having the prolapse of the first haptic to a one particular level only, and after that my staff gets it screwing the guarded delivery of the IOL. So that is very very important. It should be very guarded, and once the haptic is there, I am holding this needle with one of my hand just to see that it is free. Then I am going inside, and here either total thing can be done by the staff or you start having. The first haptic should come very gentle, and you should put this into the needle. That is very very critical. If you can't put this into the needle, then it becomes a problem because your both hands are tight, you don't have any extra hand. So either you will leave the needle, you will leave the IOL injector, then it may touch the cornea. So you should be very very cautious that the first haptic should go inside the needle. You can have a experience. Initially we use 26 gauge needle. With the experience you can go to thinner needles. Having the thinner needles with the comfort of having the with the minimal bulb at the end of the surgery will also retain the IOL haptic outside the sclera. And this is an important trick where you should do handshake, put it inside, hold it with the other hand, and after holding it with the other hand, you have to go inside the needle again, and once you enter into the needle, it becomes easier. But this haptic is really little tricky, and if you do lot of manipulation, then what will happen? This haptic will have a kink. That is a disadvantage with the sensor lens than the CT Lucia, because CT Lucia is having a higher memory and kink is not maintained after the surgery, so it is having that advantage. But because of non-availability, our all experience is with the sensor only. So in the patients who are having an iris hook, this particular area where you can see the superior nasal side is like this, superior temporal side kind of thing, that it is not coming very comfortable because of the iris hook, but you have to have a placement of the iris hook in a plane where it should not disturb the surgery. So this is a special thing, and after this you have to do a cautery. The cautery, heat cautery, and the people have used the bipolar cautery also, but we are just putting the tip of the any metal instruments heated and can also be used. It goes very good with the needle. You can have a 18 or 20 gauge needle heated up, and then it can be used the same way. The tip of the haptic end should be twice the diameter of the tunnel, so it should be big enough, so it should not slip in later on, and you can see gradually it centers. You have to put this bulb into the scleral tunnel end, and it should be covered, well covered by the conjunctiva. And these patients who are having 3 mm or plus incisions should be sutured. Hypotony is not required and not advised at the end of the surgery, because with the hypotony you will have a problem. The well centration of the IOL can be seen. There are typical pearls which are very very important. I will go very fast because of the time. That particularly you can choose the particular IOL in plan. It is very good. Needle attachment. There are few people who use the needle with the syringe hub, but when you are removing the syringe, if it cause too much tight, then it can be a needle causing inside the injury. So I use bare needles, but some people prefer with the syringe. And the lumen should be 26 or less than 26 gauge, means 27-30 gauge. It is not easily available. With the 30 I had a problem, so we are still using 26 gauge. We don't have 27 gauge readily available in our OT. The infusion really helps to keep your eye firm. Centration is much required, and it gives a very good results if it is a centration, though the lenses are spherical lenses which are less sensitive than the aspherical lenses. But still the centration gives you a lot of other comforts, because the some part of the pupil is having aphakia, then there is some kind of glare which we don't want to use. Microforceps are essential to be there inside the OT and it should be proper, it should be in proper holding. There are different variations, you have a straight, some curve, but with the experience you start having your own which forceps serves you better. The volume definitely matters. Volume means that what you want to do, and it should be really thin, and the bulb at the end should be double the tunnel, otherwise sometimes there is a slippage, decentration, or the one haptic goes inside the eye itself. Marking is very very critical for the centration. Instrumentation is definitely required. AC maintenance or the maintenance through the pars plana helps you, and peripheral iotectomy can be done in the patients where you feel that IOL and iris are having some issues. So for making a more comfortable things, you can do the things. Bulbs should be buried, they should not be exposed, otherwise there can be a track from which endophthalmitis can happen. Final verification for centration and adjustment of the centration can be done by cutting or increasing the bulb size, or not doing the cautery if it is not very well centered. Learning curve is there, but once mastered, it is a big help, because the situations may arise where you need to do it as a primary surgery. Thank you very much.
Dr. Virenwas, I just wanted to ask, you mentioned PI. Because we are placing the lens in the sulcus position, there
It
is
is
no
slightly
chance of...
behind the lens. It is lens is not exactly into the sulcus position. It depends on that you are having a the entry at the 1.5, 2 or 2.5.
Yeah.
If it goes far away, then the lens is little anterior.
Basically,
if it is 1.5, the lens is slightly posterior.
it's in the pars plicator portion.
Yeah, but PI is not a must for SFI.
It's not must.
techniques,
If you feel that is there required, then I say. Yeah, it is not for all patients.
If you see, there are a lot of
Majority of the patients we don't do PI.
So now we have this X-Knit tool kit box available. So when we are passing that needles, so these needles are available with the silicone sleeve on the needle. So once you have engaged the haptic and you have pulled out the haptic, you can just pass that silicone sleeve from the needle tip over the haptic, so that the haptic doesn't get slipped off with the manual
Yeah.
version. So that
What we
X-Knit
have done is
technique,
that you insert the haptic fully into the needle, then you leave it, then also it doesn't come out. Yeah, but you are correct. That can be also used.
Dr. Agarwal, have you tried Oro lenses, 3-piece Oro
No,
lenses?
we wanted to use, but not we are not used.
Okay.
Right now, actually, what happens that we are keeping a library of sensor in our OT for all kind of sorts of issues. Sometimes there is a PCR, you want to do optic capture. So we are having a library of that. That's why we are having that lens only. But otherwise, you are correct. The Orolab can also be tried.
Oh, actually, there's a catch in this. These 3P lenses from Sensor and Alcon, their haptics are a bit malleable. But if you look at the 3Ps of Orolab, the haptic is very strong, very thick. It is
I
not
don't
easy
have
to...
any experience.
No, I'm sharing the experience.
Yeah.
Because Orolab 3Ps,
It's more stiff.
it is cheaper, but honestly, the haptics are not really good. You might land up in increasing your complication rates.
But no financial interest. The Alcon lenses are having more like a J loop, so it is very difficult to untangle into the 26 gauge. Sensor is little C loop kind of thing, so it goes
And
easily.
basically, Oro injector is not very good. So it's
Yeah.
difficult
Okay,
to
okay. It need to be a guarded injector. That is very very
So
essential.
again, a person who is used to the screw injector, he can use Sensor. The person who is used to the push kind, he will be comfortable with the Alcon injectors. No, I am not comfortable with Orolab. I am talking about the injector.
Malleable. What
Injector.
actually happens when you are going for the trailing haptic, you need to bend it, go inside, it should open, and then go into the needle.
So I am talking about the injector. The
And what's your
sensor
view
and-
about the iris claw lenses, posterior iris claw lenses?
No, I don't have personal experience of iris claw. I want to do it, but somehow it has happened that I was doing skull fixation since very beginning. So I shifted to Yamane, and I'm not using iris claw. But surgeon in our hospital are using iris claw, and the results are really good.
Yeah, I have used both. I think they both work well.
They
Yeah.
both
Iris
work
claws-
well. Only the problem is, sorry sir, this technique is very nice. Cranber also propagated it. But we as anti-segment surgeons, I mean, I do the trocar, I put the past on a trocar and everything. But it's always been in our country, SFI, मतलब VR वाले करेंगे, anti-segment वाले कम करते हैं. So iris claw is very fast and very steady. But when you don't have an intact iris, then SFI helps us. Otherwise,
No, I
iris
think-
claw is very good. The results are very
If your
comparable.
pupil is good, then
I think it's still my comfort is because iris claw you need to order in advance.
Yeah.
And this is available. So even if PCR happens, nuclear drop happens, we are surgeon do it all complete, then we can do Yamano then and there.
basically
So
iris
patient
claw,
does not even know that the two surgeries are required or one done.
Yeah. So Iris law actually, when sir, the Iris law by XL, again I use Aioc Iris law, Apasami Iris law, Freedom, XL lens from Chennai. The Iris law
Very,
is
very good
very
lens.
good. Times they said Dr. Ravijit is the and JK Reddy is
No,
the
Iris
man.
Glow is a very good lens.
No, so they are very,
Surgeon in
they are
our
not
own
expensive.
hospital is
No,
using
they are
that
not
and is very
expensive.
happy.
We can keep a library of it also. I mean, we in Chaitram have kept a library because lot of people come. They are very cheap.
Uh,
So I mean, it's a very good lens.
It's a very
I
cheap
don't
also.
know, next session
and
is here. If any people from the next, for the next session. Yeah,
Yes, we'll-
okay, you can come on the dais.
Still we get to
Our
five.
session
Still
is
we
till
got 5 minutes.
11:55. We
Okay,
have,
we are on
we have,
time.
we are on time.
Okay, sorry.
And secondly, these lenses are very cheap and takes hardly 1 to 2 minutes extra. Surgery is very quick.
No,
compared to
surgery
this.
is very quick, definitely. Iris
With Iris
Glow is
Glow.
very quick. Yeah.
So I think there are many ways to handle these situations.
Yeah.
And Yaman is very, very good technique.
Yeah, very good.
And only thing you require, sometimes you require assistant to hold one side or
Yeah,
it will
you
step,
require a
otherwise.
good assistant.
The only one more comment
Otherwise
I wanted
you
to
can-
ask.
yeah.
You mentioned light battery operated cautery you need for this.
Yes.
Can we use the normal cautery which we attach to the phaco machine and do the bulbous and
No,
venous?
that will not do. No.
So we need to have a battery operated
You have to have
cautery.
a heat cautery.
Heat cautery or bipolar cautery, and some people
No,
have
so
tried the
bipolar cautery,
retinal laser,
bipolar cautery is the one which we are attaching to the phaco machine, the cautery what we use. It's a bipolar
but
cautery.
not used. We are not
So
used
we are
it.
using only battery operated cautery.
Yeah.
And how
But
do you
some people
how
have
do you
used even the retinal laser also.
Yeah, so
Yeah.
how do you keep, store the battery operated cautery once you open the battery?
ETO.
You're ETOing it. The cell and all, it is not harmful at all.
Yeah.
Okay, thank you, sir.
Thank you. Actually, the slides of the other session came here, so I asked the time. Thank you.